It's great to be with everyone tonight. I am really happy to be here, and we're going to spend the next hour or so together. Before we begin, I thought I'd tell you a little bit about myself. I am a prosthodontist. I practice in the city of Toronto. I did all my training at the University of Toronto, and I currently hold a number of affiliations, and the one that I'm really excited about is my new appointment as resident faculty at Spear Education. So like many of you here, I wear many hats, and these are just some of them. The other platform that I have is a group that I founded called Women in Dentistry, which is a group that was founded back in 2010 with the mission of educating, empowering, and elevating all women in the dental field. So we're really excited about that. Despite the fact that I wear a lot of hats, the majority of my time is in fact spent in private practice. So like many of you watching tonight, I am a clinician, a wet-fingered clinician that runs into the same challenges and trials and tribulations as all of you guys watching. And I'm part of a multidisciplinary team of specialists situated in Midtown Toronto called Prosthodontic Associates. And these are my team members that I can't do what I do without them. So I'd like to acknowledge them as always, because they're really, really important into how I practice. And if you want to connect with me, please feel free to reach out. Of course, social media these days, feel free to email me at speareducation, ehabsha@speareducation.com, or of course, connect on various socials. So enough about me. Let's get started with tonight's program. So the lecture that I have tonight is ceramic materials and cements and keys to predictable and aesthetic outcomes. And what I'd like to go over are just the fundamentals of dental ceramics, give you an update on dental ceramics, and then we'll focus in on cement and cementation techniques. And throughout the presentations, I'm going to show you a number of clinical slides to kind of showcase the content that I have. But to start off with, let's start off with an update on dental ceramics. And it's really important to understand that there are three main classifications for dental ceramics. We have our glass ceramics, which is basically the feldspathic ceramics. We have our particle-filled glass, as well as what we consider polycrystalline ceramics. And we're going to cover all of these different types of materials. But I think it's important to understand that historically, there's been an inverse relationship between aesthetics and strength, meaning the more aesthetic the material was or is, the weaker it is, and conversely, the stronger the material was, the lack of aesthetics is there. So if you look at a graph that demonstrates a ceramic flexural strength, you can appreciate that the weakest material is in fact your feldspathic porcelains. And that weighs in, or the strength there is between 60 to 70 megapascals of strength. And as we move along with the various materials that we have available, we can get materials that are, the glass ceramics that are infused with a material like lucite, for example. So that would be your IPS Empress, which gets a little bit stronger at 120 megapascals. Even stronger is lithium disilicate, which a lot of us are familiar with, of course, otherwise known as Emax. Has a flexural strength of anywhere between 360 to 500 megapascals, depending on how it's bonded into place. And then we reach our zirconias, and we have our conventional zirconia, which are the strongest material at over 1100 megapascals of strength, and the high translucent zirconia, which are 600 to 700 megapascals. And so if you look at this graph, you can appreciate that the weakest material, the feldspathic, is in fact the most aesthetic, and conversely, the strongest, the conventional zirconia, was historically considered the least aesthetic. But what I'm going to do throughout this presentation is show you how the materials have advanced, what materials we have available today, and what I use most in my clinical practice. So to start off with, I'd like to review our glass ceramics. And when we talk about glass ceramics, you have to think of this material as, our feldspathic material, which is essentially composed of a glassy matrix that comprises porcelain. And it's created by layering glass-based powder and liquid materials together. And it has extremely high aesthetics, excellent aesthetics at giving us a very high translucency. However, as I mentioned before in the graph that you saw earlier, it's got very low mechanical properties. The flexural strength is only between 60 to 70 megapascals. And so how can we use this in clinical practice? And the reason we can use it is that the strength of this material is derived by bonding onto enamel. And so this material could be made extremely thin, less than 0.5 millimeters in strength, but its indication is really only for veneers. And with that, only specific veneers, veneers that have enough enamel to bond onto. So not a lot of unsupported porcelain. And so this is an example where a situation where you can close diastemas, veneer material with the feldspathic porcelain. Another example is a patient here who's missing who presents with a peg lateral. Very simply, a very conservative indirect restoration is to do a porcelain veneer where you can very predictably prepare the tooth. You can use depth reduction burrs as the ones you see here that reduce the enamel to 0.3 millimeters. We can then finish off the preparation and create a veneer that's made out of, in this case, a feldspathic material, which gives a very aesthetic outcome to the patient. And you can see that there. But because of the innate weakness of feldspathic porcelain, the second classification of ceramics is one which is a lot stronger, where you can infuse this porcelain or feldspathic with fillers. And the fillers are what gives it the strength. So the fillers could be comprised or consist of a number of materials, including, for example, lucite, which is what we otherwise know as IPS Empress. We can infuse it with lithium disilicate, so otherwise known as Emax by Ivoclar, lithium silicate, zirconia reinforced lithium silicate, and other materials. And so these fillers increase the flexural strength of the material to anywhere from 360 to 500 megapascals of strength. And so these materials can be more widely used in numerous indications, including veneers, anterior, posterior crowns, inlays, onlays, and select fixed partial dentures. And so it's this classification of ceramics is very widely used in dentistry. And if I can just focus in or zone in on the lithium disilicate material or Emax, that this is a material that I use mostly in my practice, and it is comprised of lithium silicate crystals in a glassy matrix. And the material, as I said before, is much stronger than our feldspathic, and it's stronger of the particle-filled glass materials as well. And it consists of a number of materials that you can see up on your screen that are all combined together and formulated in these blue blocks, which is the pre-crystallized state of the material. And in this blue phase, or the pre-crystallized state, you have 40% isolated lithium metasilicate crystals in a glassy matrix. So the material is actually milled in this pre-crystallized state. It's not strong at this state, but once it's crystallized, you have the infusion of the lithium disilicate crystals in this glassy matrix. So it's 70% fine-grained lithium disilicate in the glassy matrix. And you can see that that Emax comes in a number of different shades and translucencies, including anywhere from the A to D shades. Bleach shades are available, and it's available in high, medium, and low translucencies. And your finishing options could be either just to glaze it, to stain and glaze, or to cut back and layer. And so if we look at some of the blocks that we have, this is, for example, low translucency, and it's ideal for full coverage restorations, which, as the name implies, the low translucency can allow for blocking of dark restorations, or it can mask discolored tooth preparations. And so it's imperative that every time you provide your patient with an all-ceramic crown, that you provide your laboratory with a shade of the actual tooth preparation. So this is an example of a stump shade guide or the abutment shade guide, and you can see that it comes in a number of shades. And you can appreciate that within a given mouth, you can have multiple shades depending on the teeth, the underlying teeth. And so this slide over here depicts a veneer or full coverage restoration on the number 8, and that tooth is endodontically treated, hence the need to full coverage, whereas the adjacent tooth, the number 9, is prepared for a porcelain laminate veneer. And so you can appreciate the difference in shade. So by using the stump shade, your laboratory technician can create a replica abutment that is the identical shade of your preparation of your tooth, and select the appropriate ingot for your all ceramic crown. And so this case here of this lady who was very dissatisfied with the aesthetic appearance of her smile, you can appreciate the fact that she has a number of restorations on her anterior teeth. And she had just turned 50 and said, it's time for me to take care of myself. And in so doing, wanted to enhance the aesthetic appearance of her smile. So we proceeded to treatment plan her for replacement of the existing crowns. We whitened her teeth. And you can appreciate in this slide as well that there is a difference in the shade of the abutment teeth. So the number 9 is much darker in comparison to the other teeth in the anterior maxilla. And so in this situation, the lab technician selected a low translucency bleached shade of Emax, or of lithium disilicate, that allowed us to provide the patient with a uniform aesthetic outcome. So you can appreciate that despite the fact that the abutment teeth were different, that the final outcome is uniform. And she was very pleased with her 50th birthday present to herself. This is another example, and this is a slide that I showed before, of a gentleman who presents with dissatisfaction with the discoloration of his maxillary anterior central incisor, or his number 8. And while we reviewed a number of treatment options for this gentleman, including orthodontics and more extensive veneer options, he elected to proceed with just addressing the anterior 2 teeth, the front 2 teeth, the number 8 and number 9. And so we proceeded to prepare those teeth for a full coverage restoration on the number 8 and a veneer on the number 9. And in selecting the shade, you can see that one is an ND8 and the other is an ND2, so a much lighter abutment for the veneers compared to the crown. And in this case, we pressed the final restorations, and we'll talk a little bit about fabrication of glass ceramics in the upcoming slides. And the case was finished like so, and you can appreciate that on the cast, on the final cast, you can see that the teeth look dissimilar. And that's, of course, because of the use of different ingots in this situation. Whereas in the oral cavity, the crowns, or the veneer and the crown, look very uniform in its presentation. And so various blocks can be used in different indications, and all you need to do as the clinician is provide your laboratory with the stump shade as well as your desired shade to achieve, and then they can select the appropriate blocks to use for the particular case. And when we talk about fabrication of these glass ceramics, you have two options for fabrication. One can be the pressed option, and the other is milling. So just a quick overview of what pressing is. A pressable ceramic is a ceramic that can be heated to a specific temperature and forced under pressure to fill a cavity in a refractory mold. So it's essentially like the lost wax technique. And you can conventionally wax up these restorations and then go through your typical process for investing and injecting the ceramic material in there, which makes it a pressable material. And once it's divested, you can polish and end up with your final restoration. Now, the nice thing that we can do, of course, with our digital workflow, which I am complete converted digital workflow dentist, I do all of my dental restorations are done both for implants as well as tooth-supported restorations using an intraoral scanner. But sometimes it's nice to have a fabrication method that's somewhat hybrid. So rather than going only pressed or only milled, what we can do these days is what I consider essentially like a hybrid digital workflow, where you can provide your laboratory with the intraoral scan, and then they can take that material and design essentially your wax up, if you will, that's to be pressed in a printable material. And so if we go through the workflow, your wax up would be a printed material that's that's 3D printed off of the digital plan from the laboratory technician, and then it's of course sprued, invested, pressed, devested, and finished. So that basically summarizes the pressed workflow. The alternative, as we're all familiar with, is the milling workflow, where you can mill a number of restorations using various milling machines to create your final restoration. And as you can see in this case, the Emax is milled in its pre-sintered state, so in the blue block. And we know that the CAD portion allows us to visualize the restoration margins. The lab technician creates the appropriate restoration, and then it's milled appropriately and finished and finalized and delivered. So this is one of the first cases that I did using a digital workflow, and the case worked out really beautifully. And it's a very simple and straightforward workflow. And in this case, we used Emax as our appropriate material. So we've covered now our glass ceramics, our particle-filled glass. Let's talk a little bit about the polycrystalline ceramics, or alumina and zirconia. And zirconia, as we all know, is a very widely used material, and it's a very strong material. And people have gone so far as to say, well, zirconia is a ceramic steel. After all, it's on the periodic table. But we should know that it's not zirconia that we use in dental use on the periodic table. In the periodic table, it's zirconium. What we use in dentistry is, the zirconia ceramic is used in dental applications is zirconium dioxide, which is stabilized by the addition of yttrium oxide. So we'll talk a little bit about what yttrium does to zirconia. Now, this material is very, very strong. It has a high strength and fracture toughness that can exceed 1,000 megapascals. And because of this, it could be made very thin, so up to about 0.5 millimeters in thickness, which is adequate for strength in its monolithic iteration. And historically, as I mentioned at the beginning of the presentation, the zirconia was not very aesthetic. And you can see in the slide above, it was, very white. So when I first started providing patients with zirconia restorations, they weren't necessarily the most aesthetic restorations, but that has certainly improved over the years. And initially what we would use, we would have, to offset that, we'd have a zirconia core, which was very strong, and then layer feldspathic porcelain, but we would see delamination of the porcelain. So that's kind of not what I do anymore, not what we do anymore. We're doing more monolithic materials. So suffice it to say that when we think about conventional zirconia in its monolithic form, its indication could be widespread for crowns, fixed partial dentures, and implant-based restorations. And the preference is to have a monolithic, well, that's the sort of standard, to have a monolithic material with the ability to cut it back on the non-occluding forces, so on the non-occluding surfaces. And you can cut back a little bit and layer some porcelain if you wish. So some examples of this material, and you probably see on the screen, various materials that you use in your day-to-day practice: Brexer, Emax Zircad, Pertau by Zirconzon, or Katana Zirconia. These are all just certain materials that comprise conventional zirconia. Now, we also have the ability to have a more aesthetic material, a more high translucency zirconia. And higher translucency is achieved by the changes in the yttrium level in the material. And so by altering the yttrium levels, you can get improvement in aesthetics. But the flip side of that is that you do, in fact, have a decrease in flexural strength. So the high translucency, or the aesthetic zirconias, are weaker than conventional, but yet stronger than your particle-filled glass. So the strength in that classification or category of material is somewhere around 800 megapascals of strength. Now, the translucency is quite variable based on your manufacture, formulation, and production process, as well as sintering time. So understand the material that you're using. And the key to this, and what I want you to really understand, is your preparation design differs depending on your zirconia. So that's why I had this in flashing. Understand that your preparation design will be different if you're planning to use a high translucency material versus a monolithic conventional zirconia. So for our conventional material, so the 3Y-TZP, you can have feather edges or 0.3 millimeter margins. It could be a very minimally invasive, minimal reduction with feather edge margins. Our vertical prep margins, 0.3 millimeters, and your axial wall reduction could be as little as 0.5 millimeters to 1 millimeters. That's for your conventional zirconia. Conversely, your high translucency or your 5Y-TZP, you need 0.8 to 1 millimeter margin and 1.2 to 1.5 axial wall reduction. So that mimics more of towards the particle-filled glass classification of our ceramic material. And some examples of this high translucency or the 5Y material are listed up on the screen. Bruxer, Emax Zircad MT, Pertau Interior. So most, zirconia manufacturers will have your conventional zirconia as well as your more aesthetic, more translucent material, which is stronger than your particle-filled glass, but weaker than the 3Y-TZP or the conventional zirconia. Now, wouldn't it be great to have kind of the best of both worlds, to have something that's strong and aesthetics? Well, that's the newest generations of zirconia. And one example of this material is the zirconia by Ivoclar called Zircad Prime. And other manufacturers have their version of this. But this is essentially a gradient technology where there's a combination or gradients between the 3Y, which is the stronger conventional, to the 5Y, which is more aesthetic and more translucent. And this material could be used more, widely used in the oral cavity. And this is an example of one case of full mouth reconstruction that we did using this material. And you can appreciate that we restored the anterior and posterior restorations, as well as the implant supported restorations using this material. And these are the digital scans that were derived, and the models were printed, and the restorations were milled out of this Zircad Prime zirconia, and the case finished with a really beautiful outcome with the translucency as well as the strength. This particular patient had a very strong parafunctional habit. She was a full mouth reconstruction that required the increase or recovery of the loss of vertical dimension. And we felt comfortable. We wanted to use a zirconia material, and in this case, the Zircad Prime, which really gave us very beautiful outcomes for both the implant supported restorations as well as the two supported. And the fabrication methods, unlike our particle filled glass, you can't press zirconia. So it's really milled, and it could be milled out of chairside blocks or larger pucks. There is now a lot more research coming out about printing zirconia. So that's going to be more readily available, where we can have printed materials made out of zirconium dioxide. So stay tuned for more information about that. And the introduction of the chairside mill blocks has really changed the way chairside dentists operate, because up until recently, certainly in Canada within the last 5 years, the chairside blocks were introduced. Prior to that, it was only the large blocks. And remember, though, that the blocks, whether it's the blocks, does require sintering, or the lab-made restorations require sintering. And following sintering, the processing options exist to either just stain and glaze, cut back and apply porcelain, or just polish. And so again, the chairside blocks are available for single units, implant-based as well as tooth-based. And then, of course, the larger pucks can be used for a multitude of options, ranging from the single crown to multiple fixed partial dentures and fixed implant-supported prostheses as well. So as a recap, our main classification of dental ceramics, as you know, as I showed you at the beginning of the lecture, your materials range from the feldspathic to the conventional zirconia. But somewhere in between is your resin matrix ceramics. And these materials are really quite nice, particularly for the chairside dentist. They're comprised of an organic matrix with highly filled ceramic particles. So it's comparable to a ceramic material. But the nice thing about it is the modulus of elasticity is comparable to dentin. And it can be very easily milled and adjusted intraorally without the need for sintering or crystallization. So that's a real draw for anyone who's doing chairside milling, where you don't need to spend the extra time to either sinter or crystallize as you would for zirconia or particle-filled glass. And the indications for this material are for inlays or onlays or crowns. And so if you look at the options available to the chairside clinician, you have your resin matrix ceramics, you have your glass ceramics, your particle filled, and your zirconia. And the fabrication methods for the resin matrix ceramics is just really polish and stain. And as you move to the particle filled glass and the zirconia, you're doing either crystallizing or sintering in a little oven. So it takes a little bit more time. And so now that you know the materials that are available, again, in broad strokes, the classifications of dental ceramics, you can appreciate that the materials, the feldspathic, the particle-filled glass, et cetera, have a higher translucency, higher aesthetics, however, lower strength compared to your high translucency zirconia and conventional zirconia, whereas the materials on the right have a lower translucency that has the masking ability to mask any discoloration, and higher strength, and the indication is more widespread for crowns, fixed partial dentures, and implant-based restorations. And what's important to understand is that the weaker materials rely on the adhesion of the material to the tooth, so adhesive bonding, whereas the zirconia and certainly the particle-filled glass can be either adhesively or self-adhesively bonded or cemented. And so if I've confused you about the difference between, bonding and cementation, that's perfect, because I'm going to just go ahead right now and explain the difference. So let's talk about cement and cementation techniques. And so this I find, when I structure my lectures, I always like to include questions or cover topics that I get from a lot of my referring dentists. And one question I had, of course, was, what's the difference between all the ceramics and zirconia and Emax and Celtra and all the other materials? So I've covered that in the first half of the lecture. The other question I get is, how do I bond things? How do I cement things? When do I use an adhesive cement? What is an adhesive cement? What is self-adhesive? So these questions are often posed by my colleagues. And there are a number of options, and there are in the marketplace hundreds, if not several hundred different manufacturers and different cements. So I'd like to kind of deconstruct the confusion around dental cements, and hopefully give you a framework so that you understand, don't worry so much about the brand name, but understand the classification and what the specific cement is meant to be used for, so that you can bring that into your day-to-day practice. So with that, let's classify cements into three categories. So three main categories. You can see I like categories. I like categorizing materials and in this case, cement. So at the bottom of this pyramid, we have our conventional cements. And the conventional cements by brand name are your zinc phosphate, your carboxylate, your resin modified glass ionomer, et cetera. Those rely on the micromechanical retention of the cement to adhere the tooth, the restoration to the tooth. So it's purely micromechanical. On the top of the pyramid, we have our adhesive cements. The adhesive cements do not rely on any retention and resistance form of your preparation. They rely only on the chemical bond between the cement and the restoration, bonding that to the tooth. And these are some examples of adhesive cements. So at the top of the pyramid, we're relying on bond strength, the chemistry, but that comes along with a lot more steps, a lot more clinical steps. The bottom of the pyramid is a lot more user-friendly, easier to use. You just mix up zinc phosphate. I don't remember the last time I used that, but you mix it up and you just slap it into the crown and you sit onto the restoration, onto the tooth. But wouldn't it be nice to combine the bond strength of the self-adhesive or the adhesive material, and the ease of use of your conventional cement. And that's in fact exactly what your self-adhesive cement is. So you'll probably see on the list here that I have noted various manufacturers of various cements. And these are, certainly in my practice, my workhorse cement. This is a cement that I'll use for most restorations. And it combines the bonding capability and the chemistry of your adhesive cement with the ease of use of your conventional cement. So when you compare all of these cements, you can appreciate that the adhesive cements require a lot more steps than compared to your conventional cement. Your bond strength is certainly highest with your adhesive cement and your adhesive protocol compared to your conventional cement. And finally, you're relying a lot less on prep retention for your adhesive cement as compared to your conventional cement. So think about a veneer. There's no resistance or retention form. You're solely relying on the bond strength of the adhesive cement to adhere the porcelain veneer onto the tooth. And so the question you ask yourself is, okay, great, thanks, Effie, but what cement do I use? And really, it's very case specific. It's very, it's a case specific situations, and you need to take into account basically 3 factors. The first factor is, what type of restoration are you looking to cement or bond? Is it a veneer where you have no resistance and retention? Or is it an onlay or a crown or a fixed partial denture? So what are you trying to bond or cement? The second question you have to ask yourself is, what restorative material? Is it a glass ceramic, which at the beginning of the lecture, if you were paying attention, I told you that your feldspathic needs to be bonded onto a tooth to gain its strength. Is it a particle-filled glass, or is it a very strong polycrystalline, zirconia, where we don't really care about the cement? You can use a conventional cement to cement zirconia if you had to. And finally, the third question you need to ask yourself is your preparation design. So the obvious is, obviously for a veneer where you have no resistance or retention, you're going to need to use an adhesive cement. However, what about a crown, where maybe it's a very short crown, maybe you have a very convergent preparation, that it's not a very retentive crown. So in that situation, you may not want to use a conventional cement. You want to get some of the bond strength from your self-adhesive cement. And so let's talk about, let's go through some clinical steps on how to, on what cement to use for what indication. So let's start off by looking at our porcelain veneers. Again, your porcelain veneer or your inlay or onlay, you're going to want to use an adhesive cement for that. And these are just some examples of various adhesive cements. Whereas for a crown or a fixed partial denture, you can use a self-adhesive cement or a conventional cement. So you have more options, again, depending on your other factors, like what material the restoration is made out of, and do you have enough resistance or retention form. And so if we just run through very quickly how to bond a porcelain veneer, you want to use a veneer cement that has specific cementation considerations. It should be light, thin enough to allow it to be light cured, and color stability is necessary. And you want to have a try-and paste that can really allow you to modify the aesthetics of the veneer, because there will be some, you'll be able to the shade of the cement will reflect the final outcome. But veneer cementation is also very technique sensitive. And so these are the properties of an ideal veneer cement. It should be light cured, dual cured. I personally only like to do light cured because it increases my working time. You must have a compatible or comparable try-and paste. It should have excellent shade matching capabilities, very color stable, high bond strength, low film thickness, high wear resistance. A controlled viscosity makes the ease of use a lot better, and easy cleanup. And so this is an example of a cement that has its comparable try-and paste. And this particular cement has an option, 5 options. So ranging from light to warm, again, depending on your underlying abutment. So you can select the appropriate try and paste for the particular patient, and your try and paste can differ for different restorations within a given mouth. So you need to really identify which try and paste you're going to use. And so you can initially apply the try and paste onto the veneer, try it into place, and once the patient approves of it, then you proceed to veneer cementation. So let's spend the next 2 to 3 minutes talking specifically about veneer cementation, because that's something that tends to be very stressful for clinicians. And I think that that's one of the most time-consuming and technique-sensitive procedure we do as dentists. So with regards to veneer cementation, the first step has to be that you have to etch the veneer. And the duration of etching really depends on your material. Are you using a feldspathic, a lucite, reinforced, or a lithium disilicate? So Empress or Emax or glass ceramics. If you're using a feldspathic, you're going to be etching with 9%, 0.5% hydrofluoric acid for 2 to 2.5 minutes. Lucite reinforced for 1 minute, and lithium disilicate for only 20 seconds. And so the idea is that the veneer is etched, and you have a nicely etched surface to bond to. Now, what I personally like to etch my veneers chairside as opposed to having my lab etch it for me, because as soon as you try in your veneer, you're contaminating it. So if you choose to have your lab etch the veneer for you, that's fine. But then you need to use a material like Ivoclean to clean off the surface of the veneer. Alternatively, you can etch the veneer chairside. So that's a choice that you should make. I personally like to etch my veneers after I try them in chairside. So then you'd want to rinse, clean, dry and the veneer and apply the silane primer. And so this slide shows the utilization of Ivoclean, and onto a clean surface, you need to apply a silane primer. Now, the caveat to that is often the silane is actually contained within the bonding resin, but and if that's the case, so if you're using Scotch Bond Universal or Adhese by Ivoclar, you don't necessarily need to have a separate silanating step. So suffice it to say, you have a clean veneer surface, apply silane to it. You want to, of course, pumice and clean off your teeth, isolate your teeth with either rubber dam, or in this case, mylar strips, a wedge, and an Optigate. You then want to etch your tooth. You want to rinse off the etch and air dry it. You want to apply your bonding resin to the tooth, and depending on the manufacturer, either cure the bonding resin or not, depending on your manufacturer. And then you apply the bonding resin onto the veneer, and then seat the veneer, apply the bonding resin to the veneer, and then again, either light cure it depending on the manufacturer or not. And then you apply the resin cement to the veneer. And these are just some examples of various resin cement. You seat the veneer, clean off the excess material, and spot cure. And I can go into a lot of detail about this, but for the interest of this conversation, we're just going to quickly go over how to cement. So, in terms of sequence, etc., we can talk about that in my veneer course. And so then we can go ahead and clean off the excess material and do the final cure. And I like to start in the midline, one at a time, and work my way back. And once that's done, you repeat the entire process. And so to summarize, for cementation, you want to etch your veneer, etch the tooth, rinse it off, apply a bonding agent to the veneer and to the tooth, and depending on the manufacturer, either cure or not light cure the resin, the bonding agent. Then you apply your resin cement and seat it onto the veneer. So that, in a nutshell, summarizes how we bond, or how I bond porcelain veneers. So now let's talk about other materials. That was a use of an adhesive cement. Well, what about our self-adhesive cement? When do we use a self-adhesive cement, or when can we use a self-adhesive cement? So this slide really summarizes the requirements you need for a self-adhesive cement. Your restoration must be high strength. So it could be anything like Emax crown, a zirconia, even a metal crown. The tooth must be retentive. So you want to have, your 4 to 60 degree taper and at least a 4 millimeter in height. And the material, the indications you can use is self-adhesive cement or conventional cement for zirconia, for metal-based restorations, or for Emax restorations. And so how does a self-adhesive cement work? So remember, it's that middle category that has the ability to bond as well as to use the ease of use of conventional cements. Well, self-adhesive cements are plausible because of the integrated adhesive monomer, MDP, which does all the chemistry. And I'm not going to get into that, probably because I can't get into all the chemistry. And also in the interest of time. But the formulation in this classification, that middle classification of the cement, allows you to use a self-adhesive cement. And this is just one example of a self-adhesive cement. This is the newest material by 3M. And I want to go through and show you there are two ways that you can use your self-adhesive cements. You can have an adhesive protocol or a non-adhesive protocol. So let me kind of deconstruct that for you. For an adhesive protocol, that's when maybe you have a preparation design that's not quite so retentive. So you want to maximize the bond strength. The way you do that is you can either selectively etch or total etch technique, and then you isolate the tooth. You etch the restoration itself. This is for the adhesive technique. Apply bonding agent to the restoration, etch the tooth, apply bonding agent to the tooth, and then you can use your self-adhesive cement and bond the restoration. And so this is what I just showed right now, is the utilization of a self-adhesive cement using an adhesive protocol, and that's to increase bond strength. You want to condition the tooth a little bit in order to gain that bond strength. The alternative, which is the way we use it mostly in practice, or the benefits of using it, is your self-adhesive protocol. And remember, we talked about the requirements for self-adhesive. In a situation like this, you don't need to etch, you're not priming, you're not doing anything because the chemistry is it's in the material itself. And you can use a self-adhesive cement for endodontic post, for a crown, for a bridge, or even for a restoration on an implant. So I'll show you this clinical case here. This happens to be an Emax crown. We have the crown, we want to pumice the tooth, and then we just take the crown and load it. In this case, I used a speed sem, which has the MDP primer already in it, and then seat it accordingly. And so that's really the way you do it. You can see it's no different than using a conventional cement, but unlike a conventional cement, you have the bond characteristics of the adhesive or the self-adhesive cement in there. And you can use also a glycerin gel that allows for oxygen inhibition, the layer not to be disturbed, and then just cure through that and finish it off. Okay. So now let's spend the duration of this talk, the next 5 minutes or so, talking about bonding zirconia, so our polycrystalline, that third classification of material. And so in order to bond or to cement zirconia, this paper published by Dr. Marcus Platz really discusses the APC concept, which is widely disseminated and widely discussed. And the A referring to air abrasion, P is for primer, and C the cement. So unlike a glass ceramic that can be etched with hydrofluoric acid, remember that zirconia, I said at the very beginning, consists of densely sintered zirconium dioxide crystals. So there is no glassy matrix. That's why it can't be etched. Glass can be etched, zirconia cannot be etched. So in order to roughen the surface of zirconia, which will increase the bonding strength, you need to air abrade it. And the recommendation is to air abrade or sandblast with the 50 micrometer aluminum oxide powder at a low pressure. So that takes care of the A, so for air abrasion. P is the primer. And remember, we talked about primer, application of ceramic primer containing MDP before application of the resin cement is recommended. Now, MDP has been effective to bond to metal oxide, and it increases the bonding abilities of ceramics to zirconia. And some examples of primers are Z Prime or Monobond Plus or Scotch Bond Universal. Now, this is recommended, but it's not mandatory because our cements, the C part of the equation, a lot of them contain MDP primers in them already, but it's not wrong to additionally prime your restoration if you wanted to. So that's P. The C is the application of a dual or self-cure composite cement, and a variety of cements are available, and these are just some of them. So Maxcem, Bicur, SpeedCem, or RelyX. So these are just some examples. So to finish off the lecture, let's look at some cases where we used this technique to bond restoration. So our full coverage restoration. So you need to have clean off your tooth. The restoration itself should be sandblasted, has to be sandblasted, and then you can try it in and then clean it off with sodium hypochlorite or a cleaning agent such as Ivoclean. So if I personally like to try everything in and then I sandblast it after I try things in. And so it's important to understand that you should not just use water, alcohol, or phosphoric acid to clean the intaglio of the cement. You want to use either sodium hypochlorite or cleaning agents such as Ivoclean. So you air abrade, and then you can use a primer if you want to use a primer. But the self-adhesive cement has the MDP primer already in it, and these are just some examples of primers you can use. Then you load your crown with the self-adhesive cement, seat it, and if it's a dual cure, you can cure the material, or it's a auto cure material as well. What about a resin bonded bridge? This is another indication. So this is a case where we made a single wing zirconia-based resin bonded bridge. So what you're looking at here is sandblasting or air abrading of the single wing, cleaning off of the abutment tooth, and then sorry about that. You can use Ivoclean to clean off the abraded abutment to the abraded wing, and then the tooth is prepared by etching it, applying a bonding agent, and then, sorry, these slides are a little bit out of sequence, my apologies, but applying a bonding agent and then the resin cement. So just to summarize, you're air abrading the restoration, you're cleaning it with something like Ivoclean, you're etching your tooth, applying a bonding agent, and then a resin cement, and curing it all together, putting it all together. And so this was a case where we did 2 resin bonded bridges for this young gentleman. Sorry, let's just go back. This was a case where we restored the lateral incisors with 2 resin bonded bridges. Okay, ladies and gentlemen, well, this takes me to the conclusion of the seminar. I hope that it was enjoyable, and I did cover a lot of material. And if you're interested in learning more from myself or from my amazing colleagues at Spear, I think the link will be posted as well, but you can go check us out online. There's a QR code that you can scan right now to sign up to Spear Online. I have some modules on there. The other members of the Spear faculty have lots of really excellent content. And if you want to dive deeper into the topics that I talked about, we do have a seminar coming up in September. It's Dr. Frank Spear, Amy Morgan, and myself. We're giving a 2-day seminar on campus in Scottsdale, and I would love to see you guys there. And we really dive deep into predictable everyday dentistry. So we have the insight from Dr. Frank Spear, the overall office management and patient factors to help get high case acceptance, et cetera, and how to improve your day-to-day practice with Amy Morgan. And myself, I will dive deeper into what we covered now in terms of materials and cements and preparation design and digital workflows, et cetera. So I would encourage you guys to to join us in September in Scottsdale. And with that, I do sincerely want to thank you for your attention. Feel free to check me out online or reach out to me via email or any other way. And now I think we've left 10 minutes for discussion. So I can, our lovely host is back online, and I suppose I can stop sharing my screen so we can just move ahead and have a nice conversation.
Oh, wow. You have 18 questions.
18, wonderful.
19. Okay, there was one, I think you may have, I don't know if you really answered it. Where did it go? Hold on, let me get to it. Oh man. It was about, well, I'll just start from the top. Let's do that.
Sure.
In what case would you use Emax for posterior FPD?
That is a really, really great question. If I have to be honest, I wouldn't use a Emax for posterior FPD at this point. So originally in practice, Emax, as I mentioned, can be utilized for anterior fixed partial dentures. But now that we have really beautiful zirconias, I've adopted using either Zircad Prime, so a zirconia material, either the gradient zirconia or a monolithic zirconia with facial cutback if I wanted to. But I very rarely use Emax for posterior or for fixed partial dentures in general.
Next question. Is there any preference for choosing milled Emax versus pressed? Do they have the same strength and aesthetics, or is one preferred over the other?
So technically pressed will be a little bit stronger. Technically, it's my understanding is it is small, a little bit stronger. I like to do the hybrid technique or pressing when I'm doing veneers. Not that you can't mill, you can certainly mill porcelain veneers. There are ways to do it very predictably, but to get that detail and the fine kind of thin margins that we can get up to 0.3 millimeters, I like to press in that scenario.
Perfect. Are you still able to fabricate feldspathic veneers using digital scans to capture the preps? I know some dental labs will only accept traditional PVS impressions for feldspathic. Wow,
Yeah, feldspathic is the
porcelain due to the limitations and accuracy of scanners.
Yeah, I mean, you generally you could, I suppose, get a digital scan and then it's created. The feldspathic would be used, would be fabricated in traditional methods. I personally don't really do feldspathic veneers because of my digital workflow. It's not to say that it can't be done, because you can take your digital workflow and make it analog in the lab, and conversely, take a analog workflow and digitize it. But that's why I use materials like Emax or, Empress if I had to, but not, I've moved away from that. And feldspathic veneers are really for specific indications where you don't have a lot of increased in unsupported porcelain, because remember, you need that bond strength to gain strength for the material.
Thank you. Next one, they're asking feather edge finish line for zirconia. Why not chamfer?
So as I mentioned, that is, you can go as thin as, a vertical prep or a feather edge margin. You certainly don't have to, but if you're using a conventional, my point is with conventional zirconia, you can go very thin and very conservatively. And the reason to go conservative is quite obvious. Conversely, just use a conventional reduction of about 0.5 millimeters. And that's more than adequate. And that's generally what I do.
In your experience with cements in regards to shade and highly aesthetic cases, when is it better to use a clear cement, white cement, or pigmented cement? And how do you communicate that with the lab?
Okay, very good question. So as we know, with various ceramics based on the translucency, you can have the show through of your abutment underneath. And so the question asks, how do you, I guess, choose between if you're using a clear or white or colored or pigmented? I always start with clear, because I also have a lab in-house. So if I want to alter my shade, I can just get my lab technician to come in. However, if you want to subtly change, typically it's the value of your restoration. You can start off with clear, and if you're not getting the result you want and you need to decrease the value, for example, you would use a pigmented or a darker cement. If you want to increase the values to make the restoration look a little bit lighter or whiter, then you would use your white cement. So it really depends. It's very case specific. In terms of communicating to the lab, photography, just get high quality photographs. And we will talk about that in the predictable everyday dentistry, you know, how you can easily communicate with the lab, what sort of tools you can use to show that. And getting that stump shade is critical, as well as your final shade. So it's really important to use that material.
Thank you. I have this question here. When you're doing larger veneer cases, when you cement one at a time, do you find that when you're at the last one, it doesn't fit?
Yeah, you guys are asking really great questions, and I really dive deep into all of these details. But so my preference is absolutely, I start with one at a time. I start in my midline, I move my way backwards. And what I also do is once I bond my single veneer, I will try in the adjacent one right next to it. And the reason I do that is because I want to confirm that my contacts are adequate, because if you just have try and paste, things can move around a little bit. Once the veneer is bonded onto the tooth, it doesn't move, the adjacent tooth. So you want to check that your adjacent veneer that you're going to bond doesn't need any interproximal adjustment. So invariably, you know, if you need to adjust interproximally, you just do it. And that's why I like to do one veneer at a time, and I etch one at a time, because I will try in my veneer and then it's now contaminated. So then I etch it after I've tried it in. So I'll do that for each veneer, and it just takes me a long time to do it. But touch wood, I've never had one debond because I really follow all the steps. So again, these details, you can go on Spear online, you can come to one of our other courses to go through that. But typically, to answer your question, you know, if one needs adjustment, it's not necessarily just at the most distal or the last veneer you cement. Tends to be that way because things could move a little bit, but you really should be checking each veneer one at a time.
When you do screw retained zirconia implant crowns, how do you seal the screw access hole since it can't be etched?
I just put a protective barrier and then just composite in there and there's enough retention in there that once it cures, it very rarely comes out. So the key is to have, of course, a solid barrier, and then just composite. You really don't need to condition the tooth.
And then for this one, it says, I've seen many zirconia bridges fail, as in fracture at the joint, in the practice I recently acquired from another dentist. What could have been the reason? Is it predictable to make short or long span bridges with layered aesthetic zirconia?
All right. So the question is, you know, the observation is that there are zirconia fixed partial dentures that fracture at the junction. And that's simple. The answer is very simple, that the connector wasn't large enough. And so I've moved away from using a thin core with porcelain on top of it. I do monolithic zirconia, so you have that strong connector. Historically, when zirconia was really ugly, and maybe that's, you know, the original dentist used it because in order to improve aesthetics, you would have a zirconia core with layered porcelain on top of it, which was inherently weaker. And so what I would do now is make sure that I use a monolithic material that has a specific, you know, enough strength in it. And then, I mean, I have never seen any one of my zirconia bridges fracture, ever. It's a very predictable means of restoring teeth.
Thank you. For this next one, it is asking about zirconia bonding. They're asking if there's research for that as an option for partial coverage for materials such as Panavia, and when are they to be used versus when are they not to be used?
So for partial coverage, because you want to be able to etch the material to gain strength and bond to the tooth, I do my partial coverage restorations with a particle filled glass, so typically with Emax. I do not use zirconia for that. However, that's also changing because, you know, we're seeing even now, I don't want to get too off topic, but, you know, the ability to bond essentially what you're doing is bonding zirconia when you're air abrading it and using a self-adhesive cement to do that. But in general, I still utilize a material like a particle filled glass like Emax to bond my partial coverage restorations.
And then for this one, it says, I was recently told not to use Reliax Unisem cement for anterior cementation because it can change color over time. A clinician said this is why he always uses Reliax Ultimate, but wouldn't the properties be the same as both our self-adhesive cements?
The Reliax, I mean, I'm not really familiar with that issue of changing of color stability, instability in the cement, so I can't really comment on that. I would speak to, your rep and use the Reliax Universal it has multiple shades and you can use it, but I don't really use Reliax routinely in my practice.
Someone is asking pumice or air abrasion preparation before cementation, which
Air braid with luminol oxide your restoration, so the zirconia restoration, and then I like to clean off my restoration either with pumice or with a non-fluoride containing prophy paste to remove any excess cement.
do you use heated composite for cementing onlays?
I don't, but you can.
Let's see here. There are so many now.
The questions, oh my goodness.
Do you ever have thoughts regarding using too strong a material?
What's the question? I can't.
Let's see here.
There's no such thing as too strong. So I don't know what the question is.
And then how do you manage, let's see here. Let's see. What is the difference between Zirclean and IvaClean?
Different brand names. They do a similar thing of removing any oxide layers from the restoration. So just different materials. IvaClean's by Ivaclar.
Thank you. And then how do you manage sulcular fluid during insertion?
So you can use either retraction cord or retraction paste. That, either if you have any concerns, you can just, or of course, rubber dam isolation. One of those options. Rubber dam, of course, is ideal, but I would say the most challenging. So I think having, good provisionals so that you have a nice clean field to bond to is ideal, is critical.
And this one says, great presentation, thank you. In the single wing zirconia case you showed that last slide, can you briefly discuss how you prep the singular area of the canine design and the depth details?
Yeah, again, a really great question about the design or the preparation for a resin bonded bridge, a single wing resin bonded bridge. Now, I just want to caution that there's specific indications for this. So it's not for every case. And again, we didn't get the opportunity to really discuss this in detail, but you need to have a number of things like favorable occlusion. You can't have a heavily restored tooth because you're relying on that bond strength of the tooth to the enamel. So let's just assume that you've met all the inclusion criteria, the criteria for doing a resin bonded bridge, again, which is beyond the scope of today's conversation. The preparation design is very, very minimal because you want to remain within enamel. So just 0.3 millimeter, just a minimal reduction to have a very fine chamfer. You can incorporate grooves if you want, or like a pinhole essentially to get a little bit of retention, but really relying on the bond strength of your material. So following specific protocols of conditioning the tooth properly, conditioning the restoration appropriately will give you the strength, or will allow you to achieve the bond strength. But again, the most important is to use it in specific indications, not all indications.
Thank you. In Bruxers, which is preferred, layered or monolithic zirconia?
Monolithic, hands down.
Do you use hemostats during cementation?
Do I use hemostats or hemostasis?
Oh, hemostasis. I need my glasses. I'm
Yeah.
sorry.
I know what you're getting at here with hemostatic agents. You can get, buildup of protein. So it's generally, I don't like to use a hemostatic agent because of the risk of having the field potentially contaminated with any with a with the biologic, proteinaceous material that can be a little bit dark. So I generally don't use a hemostatic agent because my preparations and my provisionals are so perfect that I don't get any bleeding. That's a little bit of a joke, but it's true. You need to have, good hemostasis, and you just have to be very careful when using a hemostatic agent that it doesn't seep underneath the restoration. And if so, it could really alter your aesthetics by having a darkness in the crown.
Which are the most aesthetic full coverage anterior restorations? What is your lab prescription? How do you consent the restorations before fitting?
And that's okay specific, which is the most aesthetic. In the hands of a good technician and a good clinician, you can have, anything look good. I think you have to look at the properties of the material, the translucencies that it come in, and I covered the various and the proper utilization. So whether you're using a high, a medium, or low translucency, how the lab technician creates it. So it really is fundamental from, your preparation. The darker the tooth, the more running room you want to give the lab. So you might want to have more preparation. So it's based on the operator. It's based on the operator providing the adequate information to the lab technician by having, the appropriate shade of the abutment and the final shade. And of course, on, teamwork with our technicians. Our technicians are so talented, and they can make anything look good. So, it's a combination of things.
So I still have 11 open. I'm not sure if there's, let's see here. Some of the, for air braiding, air braid after hydrofluoric acid etch. There's the I see. Okay, air braiding after hydrofluoric acid etch the zirconia wing. Ivoclean after air braid, then bond. Is there a step-by-step PDF for materials?
I'm sure I would say the folks at Spear will provide a link at some point, or I'm sure you can find it online. Details of cementing. Of cementing, but remember, you're not etching your zirconia, you are air braiding. So think of glass ceramics, so particle filled glass, you can etch with hydrofluoric acid, and zirconia, that third classification that I shared with you, the polycrystalline zirconium dioxide cannot be etched. It is air braided. So I'm sure the team at Spear can provide you guys with some with some cheat sheets.
All right. And then a lot of these are, someone's asking, what cement do you use for veneers?
Again, I'm not going to, push a particular brand, but I think you'd have to use a specific adhesive cement for your veneer cement. So that top of the classification, whether it's the Relax veneer cement, the Ivoclar cement, as long as it has those properties, just stick with the same system. So if you're using an Ivoclar cement, use the Ivoclar bonding agent, and 3M, use a 3M agent, and so on and so forth.
Do you try to match material strength as in opposing occlusal surfaces, example, or i.e. Zirconia against zirconia, Emax against Emax?
I think you just have to look at every patient is unique. Everyone has different parafunctional activities. If they have any, look at the size of a patient's masseters, and you can see, you know, if you have a patient come in with massive masseters and someone who has parafunction, then you would want to use the strongest material available, so a zirconia material. So every case is case specific. I don't have a hard and fast rule of if I have zirconia on one arch, I'll do zirconia on the other. It really is very specific to the patient.
How do you like to clean any excess cement to avoid overhangs? Do you use PTFE either side before cementing? Do you use do you floss the contacts? How do you remove interproximal cement if it has set?
Yeah, so that's a very good question. Number one is don't overfill your restoration. So have a nice clean restoration, load some material, but don't like overfill it. So I just have my assistant put some in the center and then just sort of drag the cement up. And then I have, you can use PTFE, but I generally don't, not for full coverage. What I'll do is I'll use my self-adhesive cement. I'll seat the restoration. And then if it requires some light curing, I mean, I don't wipe off the material because you don't want to drag it. So if I need to light cure it, what I'll do is I'll light cure the facial and then floss interproximally so that I don't get locked in. And then I'll cure the lingual. But you want to give the cement, the self-adhesive cement, the opportunity to harden a little bit. And then I just floss interproximally before I cure the lingual surface. And you don't even have to cure per se if it's a dual cure cement, but I floss before it completely sets.
Thank you. Let's see here. I don't know how many more of these you would like to answer, but we have 9 left.
In the interest of time, if I may, why don't we stay for another 3 minutes till 9:15 my time, and then we'll have to call it a wrap because I'm sure people are getting bored of hearing me speak. So you got 3 minutes.
All right, let me go ahead and ask a few more then.
Sure.
Can we make zirconia copings, then layer with Emax using a bonding that would allow zirconia and Emax to bond?
No. So what you're talking about is having a zirconia core with layering of a feldspathic porcelain on top. That used to be the way we did crowns. I mean, we can still do it that way. If you remember the Procera crowns, we'd have a zirconia core with layered porcelain on top. The problem with that, as I mentioned, is delamination. Because your feldspathic porcelain can shear off, you really, if you're going to use zirconia, go with a monolithic material. And if you wanted to have enhanced aesthetics, you can cut it back on the facial, on the non-functioning occlusal surfaces with a little bit of porcelain on the facial. But we're just talking, micro layering. Again, if you come to our course, our seminar with Spear, one of the other Spear courses, either online or in person, you can really, and there are a lot of great options out there, you can really learn more specifics of preparation.
Thank you. And for this last one, I feel like it might be our last one. What cement would you recommend if a zirconia restoration keeps de-cementing?
Well, you have to ask yourself, again, don't think like a carpenter, like don't just fix it. Ask yourself why something keeps debonding. If you don't, probably because you don't have enough retention and resistance form. So in a case like that, you may want to use you may want to condition your, make sure you follow the proper protocol of air braiding your tooth, air braiding your restoration, cleaning off your tooth properly, and then using a self-adhesive cement. And you can use it in an adhesive protocol, meaning you can gain additional strength by etching and bonding your tooth and by placing a primer in the restoration before you place the self-adhesive cement, as opposed to using a conventional cement. So you would have to use a cement that has some bond strength. Thank you so much for the opportunity, and see you on campus.